Welcome, Rick. So Rick Dawson's an experienced aged care physiotherapist, so great follow-on from Morag's talk. He's Vice President of the Australian Physiotherapy Association and currently enrolled at Sydney Uni doing his PhD. He focuses on effectiveness, cost effectiveness and acceptability of implementation of telehealth physiotherapy. So a really important thing to think about in terms of effective ways of delivering our interventions. So telehealth really to try and reduce falls, improve mobility and enhance the quality of life of people living in residential aged care. So welcome, Rick.
Thank you. So it's really interesting to be the fourth presenter in this segment to talk about what's happening in residential aged care. So I can keep it really, really quick. Rehab doesn't happen in residential aged care. So if you're thinking about your patients in hospital and you're transferring them to a nursing home, rehabilitation's not there. And so this talk really is from my clinical point of view, but it's also from the work that I've been doing for the Australian Physio Association about trying to create some awareness around what's not happening. But I do want to talk about some positive things that are happening as well. The photos that you'll be seeing today are all residents who have given their consent from my clinical trial, but also from Dr. Jenny Hewitt, who is a physiotherapist that's done a lot of work in residential aged care. So as a physiotherapist, hand on heart, I've worked in residential aged care since 1998. Preventing falls is probably my number one job that I want to achieve in my day, in my year. And because we as a profession understand the risks of falls in that environment. You'll see about 50% of residents in a residential aged care will fall and 10% will have multiple falls. I remember working in a facility and we had one resident that had 56 falls that year. So it's a massive problem that we're trying to solve. And the Aged Care Act that is under review at the moment is talking about, what I wanted to do is just talk to you about what's in it at the moment. And our job is, well, the Act's job is to inform safety and quality, and one of its main roles is to ensure that each facility maintains an adequate number of appropriately skilled staff to ensure that their care needs are met. At the moment, there's no real official studies around allied health numbers in residential aged care, and that needs to change. Under the quality care principles, we need to be able to provide our residents with personal assistance to move and to walk. And you know, this is a carer in a facility in Sydney providing this sort of assistance. Under the Aged Care Act, what does it say about allied health? And the words around it are really soft, if I have to be honest, and not very objective. So maintenance therapy is delivered by health professionals or care staff as directed by healthcare professionals to maintain their level of independence in ADLs. Now, more intensive therapy delivered to health professionals or care staff directed by health professionals is on a temporary basis designed to allow care recipients to reach a level of independence that meets their needs. That suggests rehab. But every time I talk to an aged care accreditor, I'm not allowed to use the word rehab. So it's just interesting. But it does exclude extensive long-term rehabilitation services required a serious illness, injury, surgery or trauma, for example, hip fracture. So the facilities need to deliver programs at least designed by health professionals or make arrangements for their residents to see health professionals. So that's why I've started using that concept around soft language. It's designed, it's making arrangement. It's really hard to objectify what you're doing sometimes. So when the Royal Commission presented their findings, there are a few specific issues that they talked about in regards to fall prevention. So clearly they wanted the aged care system to continue to work on being person-centred, deliver therapies based on clinical assessment and make sure that the individual needs of the person in regards to falls are met. And that they wanted to amend the current accreditation standards to deliver best practice fall and mobility programs. They wanted to add falls and fractures to the current mandatory quality indicator program that I'll explore a little bit later. And they wanted to do a little bit more about training around this issue. So when you look at the intervention opportunities in aged care, there's a lot happening at the moment. I could use the word, it's a little bit piecemeal. There's some really excellent work, but I wonder about the long-term investment and looking at what provides the best outcomes for the health system, the aged care system and the residents who live there. So when you look at the inputs or the staffing, there's a lot of work around staffing levels and mix that I'll be talking about, around the care standards. There's a whole new funding instrument and the quality indicators. So during the Royal Commission, it found that staffing levels were unacceptable and grossly unacceptable. If you compare us to other countries, we were really falling behind what they call a safe benchmark. And so the government has instigated care minutes. So as of this year, July 1, 2023, all facilities will need a registered nurse on site. So this is really positive for the care management and the care planning. So I was in a rural facility this week last week doing some data collection. They have 2 facilities owned by the same organisation in the same town, and one of them barely had an RN. So it's been really positive that they now have an RN 24/7, but the reality is that the government's paying for a lot of these rural facilities because the facilities cannot get RNs to these sites. And I wonder about the long-term sustainability of paying agency rates for a lot of these shifts. As of October this year, there needs to be 200 minutes of care, including 40 minutes of RN. And so what we're seeing is a negative consequence on allied health staffing ratios. A lot of the budgets are focused on getting their RN minutes up, getting their care minutes up, and as a result, they're cutting allied health. So before the Royal Commission, there were about 8 minutes of allied health per resident per day, which is not a lot. We're sitting at 4 minutes at the moment. I suspect by the end of the year will be less than 4, which is really disheartening, because if we don't actually have the bodies in the buildings delivering the care, what can we do? We've done a lot of work around, well, isn't allied health essential care? Can't we be included? And at the moment, it's just a flat out no. So as of last year, falls and fractures were introduced into the quality indicator program. This program was introduced a few years ago with 5, but now we have falls and major injury. But another one that is really important is activities of daily living. So every quarter, the facilities have to report to the government on how many % of residents fall, their fracture rate, but also the % of residents who aren't palliative care who have maintained, improved or decreased their level of function according to ADLs, which is using the Bartel. So that's really important, and that's going to lead to potentially like an Uber star rating of comparing facilities and what sort of outcomes that they're delivering. And I've been involved in expanding the clinical care through the Health and Safety Quality Commission that Carolyn's here today talking about as well, and with a focus on falls. But for each of the current standards, the consumers have to get the personal and clinical care that they need that is safe and right for them. So we could easily say that, are they getting the post-fracture care that's safe and right for them at the moment? And a lot of times it's probably a no. So the fall prevention guidelines that were released 15 years ago have been updated, taking in a lot of new research. And it's just a summary of some of these interventions. Falls can be prevented by systematic implementation of tailored interventions, so that person-centred theme. And it's not just personal risk factors that we're trying to reduce, but it's environmental. And there's an encouragement of multidisciplinary team members, themselves and their families, as a part of the care planning. So I was just talking to Morag before. What's happening in residential aged care is highly variable. One site's doing some really amazing work around using falls prevention meetings, multi-D, having the physio and the GP. You go to some other sites, well, they can't get an RN, they can't get a GP, they can't get a physio. Or they might have these people coming into the building, but the coordination of GPs coming in after hours, not coordinating with the physios, the challenges we have with discharge summaries. Allied health is not on the My Health record. So there's a lot of issues that prevent coordinated care planning to reduce falls from the site level. But what is really positive is that tailored supervised exercise delivered at a moderate intensity should be provided for those willing and able to participate. So I've taken these principles to inform the protocol that I'm testing with telehealth to reduce falls. But interesting, some of the work that Sue's and her team are doing at Flinders, that in residential aged care, we need to be able to do continuous exercise to maintain and or improve these gains that we want to achieve. So a lot of the studies that we've looked at in the updated Cochrane review that will be soon to be released is that once the program is done in residential aged care, the gains that we may have received stop pretty quick. Physios are really involved if they're in the building on post-fall management, which is really exciting. So we're involved in pretty much, if we can, within 24/7 to review the falls and look at supporting the care team to amend the care plan to make sure that future falls don't happen, implement actions to reduce the consequences of future falls. And you will see some really good falls analyses happening from site to site, looking at their own trends, which is really positive, and it's probably been encouraged to do this with the new mandatory falls indicators. So we've had, for those who work in residential aged care, ACFI, the aged care funding instrument, is dead. We're very excited about that because it had many flaws. What it did is that it increased physiotherapy minutes, but it made it to be focused on pain management only, and non-evidence-based pain management was massage and electrical therapy such as TENS. So that drove all of us physios mad when we weren't able to work at our full scope. So ANAC came along, it was designed before the Royal Commission, and it really wasn't had a wide consultation around what it should be. And the original authors of the ANAC did want to have allied health involved, but it has gone with a very much a nursing and registered nurse focus, and there are no funding for allied health whatsoever. So what is happening in residential aged care? Physio assessments are happening. We are seeing wellness exercise run by the recreational staff. So in my opening slide, you saw 3 ladies from a rural facility doing a seated range of movement exercise class, which they enjoy. What's happening in the space of restorative exercise and individual rehabilitation, I'll just explore quickly. So physios, 1% of physio students go into their undergrad training wanting to work in residential aged care. That hasn't changed in 30 years since I've practiced. Only 1% who graduate think that they're going to work with older people, but the reality is they all need to be able to work with older people because it's pretty much 60 to 70% of what we do, whether you're in private practice hospital or in residential aged care. And understanding frailty, a lot of people in the room have really informed the research around that, and that's been translated into our undergrad curriculums, which is really exciting. So physios are coming out understanding assessments that are valid for the residential or older people, such as the short performance physical battery, the Bartel, and so forth. And Jenny Hewitt's work on Sunbeam has been transformative, and COVID's been transformative. So the Sunbeam program found a 55% reduction in falls through a program of using her equipment, which is highly, as you can see in the bottom photo there, it's very complex resistive strength training that uses AI to support the progression. It's really exciting, but it's expensive. But Jenny also included lots of Otago style balance and functional exercises as well. The programs will run in groups for 2 one-hour sessions for 25 weeks with ongoing maintenance. The groups were up to 5 or 10 people, depending on how many staff they could get to lead it. But the exercises were individually prescribed and upgraded by physiotherapists. And what it found is that because falls is so problematic, that Jenny was able to show that she was able to reduce the cost of falls. And we've certainly used this research to lobby the government to provide funding for falls prevention. So when you go into a facility, you'll go into their lifts or on their recreational boards, and you'll see exercise classes every morning, and everybody gets really excited, but it is seated. Often it's run by videos, and it's always generally run by trained Cert 4 recreational workers. So there's not moderate intensity. There's no standing component. There's very little progressive resistive training component. So I just wanted to introduce you to Les, who is a client of mine. And so he was admitted to a facility following a recent fall, but he also had a very complex comorbidities like they all do, and often some social challenges as well, with his wife recently passing away. So he got a physio upon admission. And I have to agree, hospitals transferring patients to a facility on a Friday afternoon, I get it, because I'm sure there's lots of pressures you guys get about reducing or opening up some beds for the opening of your week, but there's very little. There are now registered nurses 24/7, so they will get a registered nurse on the weekend, but they certainly won't get any allied health. But Les did get a physiotherapy assessment within the first week of his admission, and he gets it regularly. This facility that he's at is really proactive. He gets every day an offer to be able to do a class of 30 minutes. And he's now doing, at this site, a modified sunbeam. So during COVID, the government funded the first sort of 150 facilities that got knocked by COVID in 2020 to do a modified sunbeam version, which used TheraBand and ankle weights instead of the HER equipment. And physiotherapists would deliver an online training through Jenny, through the Department of Health and Aged Care. And what was really exciting, there were 150 facilities, really high uptake, but we've yet to see the report on how effective or cost effective or the implementation learnings around that. And we still haven't seen the outcomes of that. But what it did, it got the message out there that restorative small group exercises that is cost effective, is possible, is feasible. And a lot of facilities are playing around funding that out of their own profits because there is no funding. But there is still, I would say, you've got a 1% chance of getting any individual free rehabilitation in residential aged care. That was the case in 2018 when Kathy Egger did her rucks getting ready for the ANAC, and I'd say that is the case now. So I don't think the Aged Care Act is fit for purpose. I don't think it's future focused. I know it's a bit late now, forget you all guys, but I hope you've all had an opportunity to talk about the public consultation that closed last week. It's supposed to start next year. I suspect that all the aged care changes that are coming our way, there will be delays. But I don't think there's going to be any changes around the quality care principles around what facilities are expected to do. The language will remain soft and vague around allied health and physiotherapy. So the APA, we've been funding really, really hard for inclusion in the care minutes. So we really tried hard to say, if a facility has 200 minutes of care, can they include physio? Can they include speech? Can they include OT? So far it's no. We've asked for our own layer of care minutes so that if the RNs potentially don't want to share their hardly fought expansion of their responsibilities and their ability to do great work, I get it. We've also asked for some sort of additional layer of funding for restorative care to maintain mobility, prevent falls and hip fractures. We've asked for a national rollout for the Sunbeam, the modified Sunbeam using TheraBand and ankle weights, and we've costed it to the government and we've proven that it's going to be cost effective, but we keep getting no, no, no. So obviously we need to keep striving, because when you talk to the residents who get physio, and for those of us who are working in residential aged care, it's so highly received and valued by the residents and their families, as Louise talked about before. And here's one of the clients from my trial. And she thought receiving physio via telehealth was fabulous, and she couldn't have imagined that she would have been given the opportunity to get physio. Since she finished the trial, she can walk better, her breathing is better, she's stronger, and it gives her more independence. So I think if we want to deliver true person-centred care, we need to be able to fund it, and we need to have these discussions about how best to do it. And that's me. Thank you very much.